This set of slides basically looks at measuring, caring, and nursing with an emphasis on validity. Validity essentially has to do with measuring what you're intending to measure and supposed to measure. As with previous discussions, concept analysis, theory, literature search, and qualitative study results can help you with item creation. As well, you can add to that a blueprint or matrix, and then you can connect the items to the citations in the literature or the themes in the codes from qualitative analysis or through concept analysis according to Walker and Avant's process. Face validity basically is called armchair validity, and the CARE-Q used face validity, looking at nurse and patients and studies that Larson conducted, and Larson has probably the oldest instrument that measures nurse caring. Additionally, when you're looking at content validity, you want to make sure that the items that are created are basically paying attention to the universe in quotes of item on the topic. And once again, you can get that evidence from various sources as mentioned previously. Theoretical validity is gained through an extensive literature search. It is important to pull theory into it, but remember also the qualitative methods can also be used because of the themes or the codes that are generated, and then you can map it with a blueprint. The item format, content, procedures for generating the items have to be carefully described if you're creating a new instrument. So looking at a couple examples, we have a very good example on the technological competency as caring and nursing instrument by Loxon. And he really looks at essentially looking at professional nurse caring competence through technological knowing. And he's basically grounding it in a theory. The Caring Nurse Observational Tool has theory in back of it as well, looking at the 10 curative factors under 3 dimensions, and also Watzlawick's interactive communication with 2 axes of communications. So looking at that, there are sub-ideas or frame of reference or main parts, humanistic aspect, therapeutic relationship, and clinical activities to organize that instrument. Individual CARE-Q behavior items were derived from a preliminary study by Larson with patients, and they provide theoretical categorizations of the behavioral items. So these are just 3 examples of instruments on caring that are out there. Also, the CBA, the Caring Behaviors Assessment, used Watson's descriptions of caring, looking at existential, phenomenological, and spiritual influence in Watson's value system, and basically forming the curative factors. So essentially that framework, the curative factors, were used in the CBA. The CNO2 used basically literature review, and basically they were related to relational and or verbal and nonverbal behaviors in the Caring Nurse Observational Tool. So looking at another kind of validity, that is content validity expert type, you typically get 5 items or more to judge the relationship of the fit of the construct and the subscales of the construct as well, if you get that far. They use the Lynn scale, which Thomas also cited, you can find in different textbooks, to have the experts judge each item using the scale, with an opportunity also to comment on the clarity of the items, the reasonability, and also the language used. So essentially the numerical value is looked at, and people create and focus on the means. They might look at standard deviations as well, but they also look at how many reviewers rated the item relevant. So this goes back to the Lynn 4-point scale. So the CBI 42 used a panel of 4 nurse experts. The instrument created by Loxon, the technological competency as caring and nursing instrument, used 13 people to assess the validity, content validity of 30 items, and essentially then ended up with 25 items. And they also had essentially looking at a very good index, and this really helped with establishing the expert type content validity. The adapted caring behavior checklist also used 5 experts, and they report the content validity as 0.92 to 1.00. So the numerical value is looked at once to reiterate using the Lynn scale. The reports are essentially on the highest points of the scale, and that would be 4 out of maybe 6 viewers, okay, the reviewers. So looking at the content validity, you can just say it's created by or established by a panel of 4 experts, essentially reiterating what in fact Loxon did, and then looking at a more expanded version of the content validity expert type that is in the caring behaviors inventory for elder persons. And so you can see the way the content validity was established, basically looking at the means and standard deviations, and then essentially removing one item and paying attention to the comments from the gerontologic experts. And here the gerontologic experts are described a bit. The nursing assistant caregiver reciprocity scale was established using extensive literature review. So in that way you would say, okay, there's theoretical validity, which is basically a content validity type, but additionally they also used a focus group and established the content validity of the expert type there, and you can see that the CVI, or content validity index, is 0.90. Construct validity gets you to testing assumptions about instruments, essentially related to theoretical constructs. So hypothesis testing validity has to do with the way you identify that in fact the instrument is going to behave. Does this really make sense? Does the way the instrument is constructed help you to explain the findings, generate the findings? So first is construct validity of the known groups type, and this means that you might have opposite kinds of people involved, such as male and female participants. You can see here on the CBI 42 that there was no difference between the genders. So that was important. Another study on the CBI 42 where the patient and nurse perceptions of nurse caring were tested, that they were statistically significant, and that was reported. So that was a t-test. Both of those examples are t-tests. And finally, on the caring behaviors inventory for elders, people were compared by the nominal characteristic of race, American, African American, white, and Hispanic perceptions of caring, and there was no statistically significant difference. You used an ANOVA or an F-test to document that. There's also a way to do construct validity using what is called the Multitrait-multimethod approach. So discriminant and convergent validity fall under here. So let's say that there are multiple measures of nurse caring. The caring dimension inventory score is correlated with a one-item caring behavior measurement, and that's just one item. And they basically had that as an ordinal scaled item, and they found that in fact there was convergent validity. Also, interviewing patients about nurses' caring behaviors and observing their behaviors using a checklist, you could compare the CNOT instrument. A visual analog could be used to measure nurse caring. That's the 10 centimeter line, looking at where that line falls and measuring it in millimeters, and then also correlating that score, that one score, with a total score in the caring dimension inventory, and that would establish convergent validity too. Discriminant validity, opposite direction, so that you might have an inverse correlation coefficient. So when the caring behavior instrument was correlated with the burnout instrument, the coefficient was 0.33, which is a low correlation coefficient even though it was statistically significant. So essentially the discussion is emotional intelligence and psychological ownership help reduce the burnout of nurses by decreasing their feelings of depersonalization. This in turn, that's an assumption, affects or improves the caring behavior of nurses. So essentially the hypothesis negative relationship between the burnout instrument and the caring instrument was not supported, because that's what they said would happen, but it wasn't. So another set of convergent validity examples, happened to come from Cronin and Harrison's instrument, the CBA, and the Caring Behaviors Inventory of Elders, CBIE, where this was checked out with 14 senior citizens and independent residing residents. So what was found was a moderately strong, non-statistically significant correlation. It was a small group, but what that means is it needs to be repeated. But it does establish convergent validity because both of those instruments measure the same construct. Another example in relation to the modified caring dimensions inventory and the empathy inventory, the Toronto Empathy Questionnaire, also a moderately strong correlation, and this is another example of convergent validity. An expanded example is seen in the testing out of the CBIE and the CBA. So this was what was reported in the actual study, but pointing out also that the sample size was too small. Factor analysis or factorial validity is another way to establish validity. And a lot of times people create this kind of a statistical process or run it when they're creating a new instrument. And essentially it has to do with the investigator thinking about how items are correlated with factors. Another name for factor is subscale, dimension, or domain. So you really have to think about it as being a correlation. Here's an example that comes from basically postpartum and peripartum, I would say, care. So that women in labor, understanding that that's important, and how interpartum nurses perceive the supportive care during labor is important. And in this study, the purpose was to develop a reliable and valid instrument that measures interpartum nurses' perceptions concerning the importance of professional labor support. It was basically done in Texas. It had a decent sample size, and they basically ran Cronbach's alpha, Pearson's R, and descriptive statistics. So what they did was they correlated the labor support questionnaire with the caring behaviors inventory and basically got a moderately strong, statistically significant correlation. So this is another example of convergent validity because beginning support is established for the reliability and validity of the LSQ, but it has to be further created. So what they're saying essentially is that labor support and caring converge. They're related. They may not be strongly related at a 0.8 correlation coefficient, but they are related at a moderately strong correlation coefficient. Here's an example from a screenshot on the article on the Caring Behaviors Inventory 42 that was published in Image, the Journal of Nursing Scholarship, where you can see that a Varimax factor analysis was run, and that you can see that the factors are listed on the horizontal, and essentially then see where the factors fell out. You can see the variance explained toward the lower left hand side and the eigenvalues, which were high. Anything that's 1 and above is considered a good eigenvalue. And then you can see on the right hand side the correlations among each of the subscales with each other. So you can look that article up if you wish. So factorial validity is really important. You can do principal components analysis if you have a one-dimension instrument, or basically factor analysis if you have more than one subscales. So you look at the factor loadings, you look at the commonality, and actually the eigenvalues are very important and can be visually represented on a screen plot. So these are really very important in relation to an unrotated factor matrix. Then there is also both predictive and concurrent validity, which are considered criterion-related validity. So predictive validity has to do with future events, and also you can look at predictive validity related to concurrent events. So essentially you talk about a criterion. That's the behavior that the test scores are used to predict. So the coefficient X is the test score and the Y is the criterion score. And so what you have to do is look at the correlations between both measures. And the predictive validity is a future measure. Concurrent validity means that you're measuring both of the instruments results at the same time using a correlation coefficient. So here's an example. The nursing assistant caregiver reciprocity scale was correlated with another instrument, a social capital scale, and you got once again a moderately strong statistically significant result. These are the references for this set of slides.